Hello. So let's start with our today's session. Octreotide mechanism, long-acting somatostatin analog, inhibits secretion of various splanchnic vasodilatory hormones. Clinical use: acute varicose bleeding, acromegaly, VI-poma, carcinoid tumors. Adverse effects: nausea, cramps, steatorrhea, increased risk of cholelithiasis due to CCK inhibition. Sulfasalazine mechanism: a combination of sulfapyridine antibacterial and 5-amino salicylic acid anti-inflammatory, activated by colonic bacteria. Clinical use: ulcerative colitis, Crohn's disease, colitic component. Adverse effects: malaise, nausea, sulfonamide toxicity, reversible oligospermia. Loperamide diphenxylate mechanism: agonist at mu opioid receptor, decrease gut motility, poor CNS penetration, low addictive potential. Clinical use: diarrhea. Adverse effects: constipation, nausea. Antiemetics: all act centrally in chemoreceptor trigger zone of area postrema. Drug mechanism, clinical use, adverse effects. Ondansetron, granisetron mechanism: 5-HT3 in receptor antagonist, also act peripherally, decrease vagal stimulation. Clinical use: nausea and vomiting after chemotherapy, radiotherapy or surgery. Adverse effects: headache, constipation, QT interval prolongation, serotonin syndrome. Prochlorperazine, metoclopramide, T2 receptor antagonist. Metoclopramide also causes increased gastric emptying and increased ileus tone. Clinical use: nausea and vomiting. Metoclopramide is also used in gastroparesis, that is diabetic persistent GERD. Extrapyramidal symptoms: hyperprolactinemia, anxiety, drowsiness, restlessness, depression, GI distress. Aprepitant, fosaprepitant, NK1 neurokinin 1 receptor antagonist. NK1 receptor, substance P receptor. Chemotherapy induced nausea and vomiting, fatigue and GI distress. Orlistat mechanism: inhibits gastric and pancreatic lipase, leads to decreased breakdown and absorption of dietary fats taken with fat containing meals. Clinical use: weight loss. Adverse effect: abdominal pain, flatulence, bowel urgency, frequent bowel movements, steatorrhea, decrease absorption of fat soluble vitamins. Anti-constipation drugs. Drug mechanism adverse effects. Bulk forming laxatives. Methyl cellulose. Psyllium. Mechanism soluble fibers that draw water into gut lumen, forming viscous liquid that promotes peristalsis. Adverse effect bloating. Osmotic laxatives, lactulose, magnesium citrate, magnesium hydroxide, polyethylene glycol provide osmotic load to draw water into lumen, GI lumen. Lactulose also treats hepatic encephalopathy. Gut microbiota degrades lactulose into metabolites, lactic acid, acetic acid that promote nitrogen excretion as NH positive by trapping it in colon. Adverse effect diarrhea, dehydration may be misused by patients with bulimia. Stimulant laxatives, bisacodyl sena. Enteric nerve stimulation leads to colonic contraction. Adverse effects diarrhea. Emollient laxatives, docusette, surfactant that decrease stool surface tension, promoting water entry into stool. Adverse effects diarrhea. Lubiprostone, chloride channel activator, leads to increased intestinal fluid secretion. Diarrhea, nausea. Guanylate cyclase agonist, linaclotide, plecanatide activate intracellular CGMP signaling, leads to increased fluid and electrolyte secretion in intestinal lumen. Diarrhea, bloating, abdominal discomfort, flatulence. Serotonergic agonist, procalcipride, NHE3 inhibitor, tenapanor. 5-HT4 agonism leads to enteric nerve stimulation, leads to increased peristalsis, intestinal secretion. Inhibits an A plus H plus exchanger, leads to decreased sodium absorption, leads to increased H2O secretion in lumen. Adverse effect of serotonergic agonist, diarrhea, abdominal pain, nausea and headache. NHE3 inhibitor, adverse effect diarrhea, abdominal pain and nausea. Okay. Okay, we are done with pharmacology of GI tract, and we have also completed our gastrointestinal system. We are entering into new system, hematology and oncology. We will read embryology, anatomy, physiology, pathology, pharmacology. Okay. Let's read few quotes. You are always somebody's type, blood type, that is. Okay. Written by blood link. You are always somebody's type, blood type, that is. The best blood will at some time get into a fool or a mosquito. The best blood will at some time get into a fool or a mosquito. Austin O'Malley. A life touched by cancer is not a life destroyed by cancer. Drew Boswell climbing Cancer Mountain. Without hair, a queen is still a queen. Prajakta Madnak. Blood can circulate forever if you keep donating it. Anonymous. When studying hematology, pay close attention to the many cross connections to immunology. Make sure you master different types of anemias. Be comfortable interpreting blood smears when reviewing oncologic drugs. Focus on mechanisms and adverse effect rather than detailed clinical uses, which may be lower yield. Please note that solid tumor are covered in their respective organ system chapters. Okay. Hematology and oncology. Embryology system. Fetal erythropoiesis. Fetal erythropoiesis occurs in yolk sac 3 to 8 weeks. Liver 6 weeks to birth. Spleen 10 to 20 weeks. Bone marrow 18 weeks to adult. Young liver synthesizes blood. Hemoglobin development. Embryonic globin. Embryonic globins. Okay. Fetal hemoglobin HbF alpha to gamma 2. Adult hemoglobin HbA1 alpha to beta 2. HbF has higher affinity for O2 due to less avid binding of 2,3 BPG, allowing HbF to extract O2 from maternal hemoglobin HbA1 and Hp2 across the placenta. HbA2 alpha to delta 2 is a form of adult hemoglobin present in small amount. From fetal to adult hemoglobin, alpha always gamma becomes beta. Fetus weeks of development, postnatal months, adults. Site of erythropoiesis, percentage of total globulin synthesis. Birth, bone marrow, spleen, liver, yolk sac. embryonic globins, adult HbA1, HbA2. Globins synthesis, percentage of total globulin synthesis, site of erythropoiesis, yolk sac, liver, spleen, bone marrow. 6 weeks, 12 weeks, 18 weeks, 24, 36. Postnatal 6, 12, 18, 24, 30, 36, 42. Adult. Okay, fetal HB decreases from fetus weeks of development till postnatal also. Okay, and what increases? Adult HbA1 increases. After birth is mainly bone marrow. Before birth, it's yolk sac, then liver, and then spleen. Okay. Blood groups. ABO classification, RH classification. Blood groups, RBC type, group antigens on RBC surface, antibodies in plasma, clinical relevance, compatible RBC types to receive, compatible RBC types to donate to. ABO classification, RH classification, RBC type A, B, AB, O. ABO classification, RH classification, RH positive, RH negative. Group antigen on RBC surface. A positive A, B positive B, AB positive A and B. Group antigen. Based on antigen, we name it. O positive has none. RH positive has RHT. RH negative has none. Okay. Antibodies in plasma. Anti-B. IgM. B positive. Anti-A. IgM. AB positive. None. O positive. Anti-A. Anti-B. Okay. RH positive, none. RH negative, anti-D. So for example, RH negative, this is my reasoning. RH negative has to be transferred by RH negative. RH positive has to be transferred by any RH positive. O positive has to be transfused by only O positive. Okay. AB can be transfused by any universal acceptor. B positive can be transfusion by B positive, right? It has anti-A. So no A. We can transfuse O and B. For A and O. Whatever is anti, we can't basically. Let it be. We'll focus on reading. Next, clinical relevance. Compatible RBC types to receive. Compatible RBC types to donate. A can receive A and O, B can receive B and O, AB can receive AB, A, B, O can receive only O, RH positive can receive both RH positive, RH negative, RH negative can receive only RH negative. Compatible types to donate to. A can donate to A and AB, B can donate to B and AB, AB can donate to AB, O can donate to all, RH positive can donate to RH positive, RH negative can donate to both RH positive and RH negative. Hemolytic disease of fetus and newborn, also called erythroblastosis fetalis. RH hemolytic disease, ABO hemolytic disease. Interaction, mechanism, presentation, treatment or prevention. Interaction. RH negative pregnant patient, RH positive fetus. Mechanism: first pregnancy, patient exposed to fetal blood, often during delivery, formation of maternal NTD IgG. Subsequent pregnancies, NTD IgG crosses placenta, attack fetal and newborn RBCs, hemolysis. Presentation: hydrophytalis jaundice shortly after birth, kernicterus. Treatment: prevention, prevent administration of NTD IgG to RH negative pregnant patient during third trimester and early postpartum period. Prevent by administering NTD. If fetus is RH positive, prevent maternal NTD IgG production. Okay. ABO hemolytic disease. Interaction: type O pregnant patient, type A or B fetus. Pre-existing pregnant patient, anti-A and or anti-B IgG antibodies cross the placenta, attack fetal newborn RBCs, hemolysis. Mild jaundice in the neonate within 24 hours of birth. Unlike RH hemolytic disease, can occur in first-born babies and is usually less severe. Treatment: phototherapy or exchange transfusion. Okay. Okay, we have successfully completed hematology and oncology, embryology part. Now hematology and oncology, anatomy part. Hematopoiesis, multipotent stem cell. multipotent stem cell, myeloid stem cell, lymphoid stem cell, erythropoiesis, thrombopoiesis, granulocytopoiesis, monocytopoiesis. This is myeloid stem cell. Lymphoid stem cells, lymphoblast, B cell, T cell, NK cell. B cell leads to plasma cells, T cell leads to T helper cells, T cytotoxic cells, NK cells. That is lymphoid stem cells, lymphoblast, myeloid stem cells, erythropoiesis, erythroblast, reticulocyte, erythrocyte, bone marrow, blood tissues, thrombopoiesis, megakaryoblast, platelets, granulocytopoiesis, myeloblast, band, eosinophilic, basophilic, neutrophilic, monoblast, monocyte, macrophage, monocytopoiesis, granulocytopoiesis, thrombopoiesis, erythropoiesis. Okay. Acute inflammatory response cell, neutrophils. Let's read neutrophil. Acute inflammatory response cells. Okay, this is going to be our last topic for today. So let's read neutrophil and call it a day. Acute inflammatory response cells, phagocytic multi-lobed nucleus A, specific granules contain leukocyte alkaline phosphatase LAP, collagenase lysosome and lactoferrin. Oxyrophilic granules lysosomes contain proteinases, acid phosphatase, myeloperoxidase and beta glucuronidase. Inflammatory states, that is bacterial infection, cause neutrophilia and changes neutrophil morphology such as left shift, toxic granulation, dark blue coarse granule, Dole bodies, light blue peripheral inclusions, oroshoncin B, and cytoplasmic vacuoles. Neutrophil chemotactic agents, C5A IL-8, LTB4, 5-HETE, leukotriene precursor, kallikrein, platelet activating factor, N-formylmethionine, bacterial protein. Hypersegmented neutrophils, nucleus has 6 plus lobes, are seen in vitamin B12 folate deficiency. Left shift, increased neutrophil precursors, that is bad cells, metamyelocytes, peripheral blood, reflect states of increased myeloid proliferation, that is inflammation, CML. Leukoerythroblastic reaction, left shift accompanied by immature RBCs, suggest bone marrow infiltration, that is myelofibrosis, metastasis. And we have successfully completed started our last topic and our today's session. Let's see what all topics we covered today. We started from reading octreotide, sulfasalazine, loperamide, diphenoxylate, antiemetics such as ondansetron, ganensotron, cloperazine, metoclopramide, aprepitant, fosaprepitant, olristat, anti-constipation drugs, bulk forming laxatives, methylcellulose, psyllium, osmotic laxatives, lactulose, magnesium citrate, magnesium hydroxide, polyethylene glycol, stimulant laxatives, bisacodyl senna, emollient laxatives, docostate, lubiprostone, guanylate cyclase C agonist, linaclotide, plecanatide, serotonergic agonist, prucalopromide, NHE3 inhibitor, tenapanor. Then we started with hematology and oncology. Started from embryology, fetal erythropoiesis, hemoglobin development, blood groups, ABO classification, RH classification, RBC type, group, antigen on RBC surface, antibodies in plasma, clinical relevance, hematolytic disease of the fetus and newborn, RH hemolytic disease, ABO hemolytic disease we have seen. Then we started with hematology and oncology anatomy section. We have seen hematopoiesis, multipotent stem cell to myeloid stem cell, lymphoid stem cells, then erythropoiesis, thrombopoiesis, granulocytopoiesis, monocytopoiesis, lymphopoiesis. Then we read neutrophils, and this was our session. See you all in the next session.